Welcome, everyone. I'm Nate Wade, Senior Director for Strategic Initiatives, and I'd like to thank you for joining our Health Talks webinar series brought to you by the College of Health Solutions at Arizona State University. The College of Health Solutions addresses the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. This Health Talk series is one way that we serve the community with timely and relevant educational talks that also provide continuing education credit at no cost. And now for a few quick housekeeping items. First, this session is being recorded and it will be posted in the near future on our website, asuhealthtalks.com. Next, our panelists will present for approximately 20 minutes each, followed by a 15-minute moderated Q&A session. Please submit your questions using the Q&A feature and not the chat feature. We value your feedback and plan to send a brief survey asking for your input about today's webinar and would greatly appreciate your participation. Finally, I would like to introduce our moderator for today's talk, Natalie Landman, the Executive Director at ASU's Center of Healthcare Delivery and Policy. Natalie?
Hello, everyone. Again, welcome and thank you for joining us. Our topic for today's session is COVID-19 is surging. How do we plan and prepare? Joining me today are two esteemed panelists, Dr. Dennis Cortese and Arnaud Bernard. Dr. Cortese is currently Foundation Professor and Director of the Center for Healthcare Delivery and Policy at ASU. He's also the Emeritus President and CEO of the Mayo Clinic and has been involved in health policy and healthcare delivery at the national and local level for quite a few decades. Mr. Bernard is currently with the World Economic Forum, serving as the head of the forum's Shaping the Future of Health and Healthcare group. He brings to us more than 20 years of experience in the healthcare industry, including home health, clinical decision support, and imaging-guided interventions and treatment. And we very much appreciate him joining us today from Geneva, Switzerland. So thank you both very much, and we look forward to hearing your talks. Arnaud is going to get us started with a global perspective, and Dr. Cortese will take us to the US and to the local level.
Thank you, Natalie. And I'd like to start by saying my true pleasure to be with you today. We have been very close to Arizona State University for the past 6 months, I would say, running a very important projects about helping employers get their employees return to work, and that particular collaboration has been enlightening, and I hope will drive a lot of value. I think we have interviewed with ASU more than 250 corporations in the understanding of their practices. So I applaud the talent and commitment of your organization. But maybe we move to the next slide. I tell you a little bit about the World Economic Forum. The World Economic Forum has been in existence for 51 years. Actually, in Davos this year in January, we actually celebrated the 50th anniversary of the World Economic Forum, and this is on the 24th of January. When we were planning to run a defining contributional session with Dr. Tedros from WHO, he had to return to Geneva in a matter of hours, because this was the day where WHO was going to convene their executive board and declared a state of emergency. And this was the beginning of the story. I remember in Davos this year with experts like Richard Hatchett from CEPI, the Coalition for Epidemics, Preparedness, Innovation, and Jeremy Farrar from the Wellcome Trust. We had this oh shit moment. It's not an epidemic, it's going to be a pandemic. And the future proved them right. That's where our mission and approach is even more relevant as the World Economic Forum, because this is all about creating the conditions for public-private partnerships. And on this slide, you see the way we organize our work at the forum. And our theory of change is obviously that healthcare systems are not sustainable. They have to transform radically. They are capital intensive, hospital centric, and they need to move in a world where technologies from the 21st century, including AI and virtual care, will help them transform, and transforming in support of health preservation, preparing and responding to epidemics, but also enabling universal access. And when we talk about accelerating the sustainability of healthcare system, we are strong believers on value-based healthcare type of models. So our program at the World Economic Forum is all about creating the conditions for public-private collaboration and coalitions to emerge. And this is what we have done over time, because if you look back into the past 2 decades, the World Economic Forum was a place that gave birth to the Global Alliance for Vaccination and Immunization. Gavi was born in Davos in 2000 and helped immunize more than 700 million children to date, raised $20 billion, and arguably averted the death of more than 10 million children in low and middle income countries. Then 2 years after, the Global Fund was launched in 2002 in Davos. And this was a moment in time where this Global Fund to combat malaria, tuberculosis, and HIV/AIDS took birth. At this point in time, we think that 34 million lives have been saved thanks to the Global Fund. More recently, we launched in 2017, after 1 year of hard work, the Coalition for Epidemics Preparedness Innovation, CEPI. CEPI was born to actually address the need for vaccines for ignored pathogens. At this point in time, we were very much focused on Ebola, MERS, West Nile virus, Zika. In the current context, CEPI evolved, and after we launched it in 2017 with 750 million in funding, we raised this year an additional 2 billion for CEPI to advance 4 vaccines that are in the current phase 3 of clinical trials, including support to the Pfizer-BioNTech vaccine, support to Moderna, support to CureVac, and support to Novavax, which are extremely interesting candidates. So maybe this is about the role of the forum, but maybe we can move to the next slide. And this is a flurry of initiative. I'm not going to go into any detail, but be aware that our initiatives at the World Economic Forum, which all of them, again, are about creating coalitions, are organized with 28 initiatives. And you see a number of COV or COVID on this slide. This is the way our program has transformed significantly over the past year in the current context. And we're very proud at the forum to be part of the ACT-A Accelerator Leadership Group, where we focus on delivery on vaccines, and we support COVAX, and we support also the diagnostics workstream of the accelerator, which aims at delivering 500 million tests to low and middle income countries in the past 12 months. Moving to the next slide. So in a way, we knew that those systems were not sustainable. The one thing we did not know so well is how much they were, in a way, incapable to resist shocks. So for us, it's important to make a difference between sustainability and resilience. And but obviously, a sustainable system has to be resilient. The things we did learn from the past 10 months, in a way, is that governance models were not optimal. I think we had certainly the Global Preparedness Monitoring Board to incubate new ideas in support of the reform of WHO, but it was too little too late in a way. The first report was produced in September 19. I really encourage you to read that report, because when you read the report, you say, oh shit, this is exactly what was going to happen in 2020. Some extract of that report are just about the emergence of a very large respiratory disease that would not be controlled. And this was published in September 2019. Then the other thing we learned is that the world has been totally incapable to promote fairness and equitable access. At this point in time, 7 billion doses of vaccines are pledged to less than 30 countries. 92 countries have to rely only on the COVAX facility. They have potentially going to access 700 million doses. So think about 700 million doses for a population of 4 billion, and to be compared to 7 billion doses for a population of 1.5 billion. I think we have a big problem there. I think this is where we need to absolutely reset our values when it comes to equity and access. The third thing we learn is that, yes, there has been a lot of virtual medicine, and we've seen some elements of modernity in the current response, such as artificial intelligence applied to understanding images of lung X-ray or CT, and we've seen virtual medicine and telemedicine develop quite a bit. But think about that. When you think about the testing results being reported to the CDC in the US, 92% of them come with no correlation with underlying conditions of patients, or preceding conditions, or pre-existing conditions. So they come in isolation, and this is at the time where the US has invested more than $50 billion in healthcare information systems, or EMR. Think about a system where forecasting is about a country telling WHO about something happening on the soil, and it takes 1 month, and then WHO, it takes another month to tell the world. This is in a context where genomics registries are existing since 2006 with the Global Initiative for Sharing All Influenza Data, actually helping vaccines manufacturer monitor the mutation of flu vaccines since 2006, 2008. And the alarm system is still the one of the 19th century when it comes to epidemics preparedness. And then there is obviously the field of prevention. We've seen what's happening with chronic disease patients, 10 times more mortality when compared to patients that are not affected by some chronic conditions, and the role of employers, which is a big field of work with ASU. The role of employers, because at the end of the day, I mean, they need to also understand how they support their employees when it comes to mental health disorders, trust in vaccinations. They can be big advocates, or that's an opportunity. So I will move very rapidly now to the next slide, and see where we see the role of the forum in the response and in the current period of the surge. I think, when it comes to right-sizing the governance models, we have a number of panels that are in existence. The Global Preparedness Monitoring Board is a good instrument, but I think it needs to move from recommendation to plans of actions, and ones that can be measured with milestones and maybe a more robust governance process. There have been some good things that have been happening during the current period. I think the access to all coronavirus tools accelerator Act A, has been really built on the principles of universal access and equity. And we've seen, for instance, that advanced purchase commitment as promoted by Gavi and CEPI, two babies of the World Economic Forum, by the way, the COVAX facility is at this point in time the only chance for emerging economies in 92 countries to finally put their hands on vaccines. Those instruments need to be protected in peacetime, and this is where we will be relentlessly focused on additional efforts moving forward. Now, we live in the world of the fourth industrial revolution, the combination of genomics, AI, interconnectivity solutions, and they're all merging together. Now, I've been amazed. I think we've been in situations where Unilever was approaching the forum with donations of close to 100 billion supply in cleaning solutions, soaps, and you name them, that could have helped the response and benefit low and middle income countries. Guess what? I mean, the WHO would not even know where to send that. I think we don't know about the demand, we don't know about the supply, and you know, there is not such a thing as an Amazon for matching supply and demand when it comes to critical supplies. It's a huge opportunity. And if you think about Amazon-based platform enabled by prioritization rules for sending critical equipment and protective equipment to the right place very early in the crisis, if you think also about building virtual inventories that can be reserved to protect certain nations or a large number of nations, I think that's an opportunity that has been solved in many industries, and to enable the supply chain matching is an opportunity that has to advance. Same thing for epidemic surveillance. I was mentioning before the kind of archaic surveillance mechanisms where country report to WHO and WHO to the world. I think with genomics data and the opportunity to monitor pathogens and map the DNA against known registries of animal disease and human diseases, there is a better way to do it. And then let's protect what has been done in the past. I think there is a Gavi for vaccines, 700 million kids being vaccinated. Maybe we can build a Gavi for diagnostics or a Star Alliance of labs. And finally, the role of employers, as I mentioned before, is important. This is where we think that conditions like tuberculosis can be managed in the workplace. We think that the employers have a huge role to play in the education of their employees on the benefits of vaccinations in the current period, where conspiracy theories are going to flourish about the potential harms those vaccines are going to create, and the mental health matter in the workplace. It's a very bizarre and strange period where we have been cut from our offices and colleagues for close to 10 months, and there are some long-term side effects to it. We cannot ignore them. The employers are not totally prepared, not well prepared to manage them, and I think there is also a big field of work that can be organized with the forum and forum partners. So a few ideas that unfortunately are still very relevant in the context of the surge we are in. Like I was telling Dennis before we started that conversation, the situation in Europe is not that much better than the one you are seeing in the US, and the political courage of implementing these protection measures that are cruelly needed is lacking, and we can understand why. I mean, people are tired of it, but this would be a huge error to think that because vaccines are approved in some countries, this would be a huge error to relax our regulation and civism in the current context. I think we will be testing for many months to come, and maybe a few years to come. Thank you very much.
Thank you, Arnaud. Dr. Cortese, I think we're ready to move on to you, and we'll do the Q&A at the end. So for all the folks out there, if you have any questions, please make sure that you put them into the Q&A box. Thank you.
Okay, Natalie, thank you very much. And greetings to everyone, all the attendees. My focus is going to be building off of this, looking at the activities that have taken place in the US and then bringing it down to at least one county and some of the work that's going on in Maricopa County here in Arizona. And I'll touch upon the ideas of responsibility and leadership, and then looking at what kinds of thoughts our community folks are working on to build resilience. And resilience basically means we're running in a practice area where things will happen and viruses will occur, unexpected epidemics and pandemics will occur, and sometimes they are expected. We can't prevent them, so therefore we have to be resilient. How do we respond to them is the real heart of the question, and how well did we do already? I'm going to just bring up my slides here. Okay, so the concept that I'm going to be building up to is the idea of a civilian emergency medical system. And it's broader than just pandemic, but pandemic is a great prototype in which to at least explore this concept. And the word civilian is deliberately in this title. And it's basically designed to improve readiness and management of pandemics in Arizona. That's what we're working on, but we can generalize it to a bigger events if we had some sort of other emergency occur, which is quite possible at least in our state, as also possible, even more likely in many other states. Last 20 years, what have we learned about viruses? This is the list of viruses that I know of that we've had since 2000. We've had SARS, influenza. In 2005, because of previous epidemics, George Bush allocated $7 billion or so to NIH to get further preparedness for epidemics in the United States. He also made a pandemic warning in his discussion. And we'll see where, I'd like to know where that money went. In 2008, we had another influenza, H3N2, we had MERS, we had Ebola, Zika. And then in 2017, 18, 19, 19, 20, we had relatively higher rates of deaths. I shouldn't say rates, but higher number of deaths in those 3 years for flu than has been our average. Average is somewhere about 12,000 a year to about 20,000 a year deaths, with a death rate of about 0.1%. But in 2017-18, the vaccine missed. It didn't actually hit the target that we actually had to deal with. We had about 61,000 deaths, and 60 million people are estimated to have been infected. 18-19, about 37,000 deaths. And the estimates I've seen for the 2019-2020 flu is estimated in the ballpark of about 35,000. So these are significant numbers, and we just accept the flu events. It's built into our psyche, it's built into our behaviors, and we just accept these deaths and high rates of millions of people getting infected. The pandemic observations that we've made in our discussions with a number of people, and I'll be indicating what those organizations are shortly. But what are the observations? One, we have a tremendous capability of failure to learning in this country. I think Winston Churchill said it once, something like, you can count on the US to do the right thing after it's tried everything else first. And we've had a lack of leadership, wisdom, clarity. vision, shared vision. The ultimate one, though, is responsibility. Responsibility is basically what leaders should feel, even when it's not their fault. They should feel responsible for things. And this, it doesn't matter where the leadership is. It's just the definition, in my viewpoint, of a leader feeling responsible. We have a lack of actually identifying what we're up against. We're in a real war here. We're in a war in the sense, at least the medical side's in a war, because we have people who are getting infected with the virus, the COVID sick, and people who are ordinarily sick all the time. We've got to take care of both of them. And in the delivery system, we have a responsibility to care for both. We don't have the luxury, like in a war setting, of walking out of the tent and put your hands up and say, time out, stop shooting. It just doesn't work that way. People are still going to get sick. We're still going to get the vaccine, to get the virus that we have to deal with. In World War II, we had 291,000 US combat deaths. And that was about a 4-year experience. Compare that to where we are in 10 months. We do not have a medical reserve corps for rest and relief. When you're in a war footing, you need to provide rest and relief with rotating forces and training. We've never developed that concept. We've had the failure at the delivery system level, the preparedness and readiness from the delivery system with regard to the logistics, the supply chain, training and retraining a relief workforce. We've had failures of the regulatory and the business model of our healthcare. Regulations, so we've had restrictions on licensing, scope of practice, malpractice exemptions have had to be introduced. Can you imagine? We need some sort of act of Congresses to make this work. Insurance linked to employment. I think in this country, we should have now put a nail in that coffin. It is absolutely clear having insurance linked to employment is a disaster. And we need to change that as fast as we possibly can. I'm not optimistic we will, but we have a clear message that we could learn from if we wanted to. The fact that we have politicians telling hospitals how to practice. The first go around, that's exactly what happened. The second go around, the hospital said, no, thank you. We know how to manage this. And they're doing the best they can, and they are under stress, but they are managing it at this point. That's the appropriate place. Failure of the fee-for-service model. It's the dominant payment model in the United States. We get paid as physicians, I'm a physician, we get paid when you're sick. And we get paid for more volume of what we do. We have restrictions on what will be covered. So what do we have? We don't get paid for telemedicine, or we didn't. Telemedicine, nurse-provided care at home, hospital care at home, independent care at home, those kinds of things are covered in capitated models, but not in the fee-for-service model. And look at telemedicine. It took some sort of an act of Congress or an act of CMS at the federal level to allow us to get paid to do telemedicine, if you can believe it. Failures of some experts, NIH, CDC. We still have a debate over masks. We should have known from day one whether masks work or not. After 20 years of viruses, we should have known whether masks or not, and it should have been absolutely clear. And if so, what kind? How do we use them? And if in fact we ran out of masks, we didn't have enough, we should have leveled with the country and said, we don't have enough masks, here's how to make your own. But we need to be clear about what is true and what isn't true. In a war footing, you don't really benefit by not leveling with the public. It comes back and bites you in the long run, as we're watching right now. CDC actions on blocking testing, tracking and tracing. Their job is to do tracking and tracing in epidemiology. What were they doing in saying, we'll do the testing? What were they thinking? And they actually blocked the CDC. If you look at the bottom bullet point, CDC and FDA actually blocked academic laboratories that were already CLIA approved to devise these tests. They were blocked for quite a while from doing that. They were prevented from doing it. And then with issues around HHS, home security, et cetera, supply chain, you know all of this, you've heard it in spades about PPEs, ventilators, testing, food, home supplies, et cetera. Okay, so the question comes, given all this catastrophe I just showed, who's going to take responsibility? The unfortunate thing is somebody's got to do something about it. So at least now in our community, we have begun to engage with a small group of large providers. These are big providers in Maricopa County. Several of them are national or certainly regional in scope, and begun to have discussions about what can we do to get ready for future medical emergencies. It's broader than just pandemics. The way we went about trying to accomplish this is starting with everything had to be virtual, as you think. As you know, we started with individual phone discussions with each of the CEOs who were very interested in participating. These are 8 delivery systems in the past who are very competitive. And frankly, still today, they're very competitive at the delivery side of things and the business modeling. But when it comes to a common purpose that's larger than themselves, they have demonstrated a real desire to try to work together to make something happen, to provide our community. Initially, we're thinking Maricopa. If it works, we'll extend it out to the whole state, but to begin to create responsibilities that will lead to better resiliency and preparedness. We had them each fill out a couple of surveys that we provided. Individually, they responded. We collated those surveys. They decided when to have a virtual meeting, when they had more time to think about strategic issues. That's different than running your operations from day to day, which we were very heavy doing in the summer, and we are again now. But there was a little break in the action, and they all met virtually September 28th for a 4-hour meeting. In the first hour, they created a vision statement that they actually worked on during the surveys, preliminary governance structure on how we might try to make this work, strategic objectives. They created a preliminary operation structure, and we went ahead and identified management and operational leaders to go to the next step. Here's the vision statement. It's very community oriented. I won't go over it all, but it has to do with being prepared, being trained, having resources, using information and data and distributing across, and also communicating with the public. The governance structure looks more complicated than it is. The predominant structure, dotted lines mean that they collaborate with, but just pay attention to the black lines, the solid lines. The leadership would be the current CEOs that we met with already. And there were 3 pillars that they decided, A, B, and C. You could guess what they are. Facilities, what kind of reserves do we have for that? This is the workforce, clinical operations, all the people delivering and taking care of the patients. And this is the supply chain, the coordination, the logistics. Below those pillars, we had some subgroups that we discussed in detail. I won't go over them at this point, but it's interesting to see what evolved here. As the discussion went, we really felt that facilities and the clinical operations could be incorporated into a concept of a medical corps. Who will be the folks on the front line? Who's going to take care of it? Now here, this is like D-Day. The troops landed on D-Day. However, if the supply chain people who are behind the scenes didn't deliver the ammunition, after 3 hours of landing on D-Day, if they decided that you already used enough bullets and we're not providing you anymore, we would have had a catastrophe. So the supply chain is not something that this group can actually control, yes, to some degree, but not totally. So we need a significant effort over here to see how we can build resilience in our supply chain work. As a result of those strategic objectives, we asked them to, sorry, I guess I went backwards there, to what are some of the key top strategic objectives you would like to have happen in each of the 3 categories: supply chain, facilities, workforce. Nothing here is a surprise. It represents what seemed to be the most important with regard to pandemic for the group that we have been convening. The post-acute care, in other words, people who have been in the ICU, they're still on a ventilator, maybe still on dialysis, but they're doing well otherwise. How do we move them out of the ICU into some other facility or location where they get continuing support for the several more weeks that they need it? thereby relieving some of the space that's in the ICUs, because some people are in the ICU who could be managed somewhere else. That would back up the whole hospital and that's what's happening. We're backing up the facilities to some degree. Workforce, big issue there, licensing the nurses, trained MDs, et cetera, managing burnout. We add one other topic, which is now off the table because it's been resolved in the last month or two. So we won't really get into the funding for Maricopa County, that we dealt with that probably through October and November. So this is the operational structure. It's the same structure you've seen, a little more clarity, same 3 pillars of strategic concentration. However, we've interjected now an operations team, and the senior leaders have identified the operational folks who would represent their organization. And we have lists of people that fall into all of these categories. Really, the CEOs have done a great job identifying some key people. And we have so far now in the last 2 months, we're working with the CMOs, particularly the chief medical officers, looking at both facilities and the workforce issue. The workforce issue is actually moving ahead right now in discussions, and we're thinking about models to develop some sort of a medical core that would be available to support emergencies if we need it, and we know we're going to. We just don't know what the next one will be, but we know it's going to be needed. The next steps, we're convening these operational teams. We're prioritizing some work streams for the strategic priorities that they will set. We already know one of them, and that would be training, maybe involving clinical credit, education, training of the workforce, relief strategies, that sort of thing. And we're going to be prioritizing other work streams in those categories. Hopefully we'll end up with maybe 3 or 4 strategic priorities that we'll actually work on into 2021. You can't handle 8 to even 20 objectives. You have to start and build that trust and build some framework. And then finally, longer term considerations are, if this actually works, if we can keep this going and extend it statewide, they will need some sort of planning for an ongoing operation and coordination function that will manage an organization to keep this alive, that with the primary responsibilities of supporting emergency preparedness and the ability to do research and education. There's a lot we can learn out of these activities. So with that, Natalie, I will finish and say thank you very much for listening.
Thank you, Dr. Cortese. We have a few questions from the audience, so I will get us started. The first question, which actually comes up quite a bit, I think, over this year, is which countries, if there are any, have done the best in terms of managing the pandemic? What can be learned from their responses, and what can policymakers do next to better prepare and plan? So no, maybe you can get us started.
Well, listen, I think it's difficult because you know, populations respond differently to different challenges. But certainly, if you look into situations like Korea, Singapore, this has been quite a success. If you look into what's happening in New Zealand or Australia, but you know, I think those are countries that have decided to count contamination in dozens or single units, and I've decided that until those single units diagnosis population would be met, goals would be met, they would not relax their effort. And I think ultimately, I think my belief it's paying off. I think it's paying off. I think we've seen numerous analysis from an economical standpoint proving that going on and stopping and relaxing, but not going to the bottom is the wrong strategy. So targeted strategies based on the prevalence of the disease in your country is certainly brutal, but in the end, it does pay off.
Dennis?
Yeah, that's a good question, because I'm a strong proponent from learning from other smaller examples, smaller states and cities and delivery systems and what have you. Maybe two observations. First, from New Zealand, I think there's something to learn there. They used the 13th century model of dealing with pandemics. They locked down, they locked in, and they locked out. And I would submit that probably in almost all the Western countries anyway, we may have done two of the three, but we certainly, like New York City, we certainly didn't lock out. Planes were still landing, for instance. And there's some basic principles, if we're going to deal with this, that you would definitely have done if we really seriously took it serious. And I guess in retrospect, it's easy for me to say that. However, it's a learning for us. And New Zealand, I think, demonstrated that. And to some extent, that's what Australia did too. And they did it at the micro levels. They did it at local levels to really concentrate on it. And I was just on the phone with Sir Malcolm Grant, and he may be on right now. So have a nice toast, Malcolm. He's in France, so the time is quite different. And I think he was going to have a drink. But Sir Malcolm Grant's gone to New Zealand. And when he lands there, he and his wife will be in a hotel supervised by the government for 2 weeks. Yeah. And he'll be allowed to go to his home, and he'll be able to be there for another 3 months or however long he's going to stay there. And he thinks that's a price worth paying to be able to be home and get there. So if you mix that in with our culture, Western culture, and particularly in the US, where we can't agree on anything, and anything that asks people to sacrifice something is rejected as an invasion of their, their independence and their civil rights. And there's some truth to that, because when you look at other countries where civil rights are not as high a priority and the freedom is not as high a priority, they probably have performed a little better by being able to get much more cooperation from individual behaviors for some reason or another, whatever that reason would be.
Dennis, that's interesting, because Australia is in a way our Western culture, right? So, but Melbourne has been under 93 days of a lockdown, not being allowed to open to other states in Australia until the time when they would have less than 5 cases a day. And so what's your take on this?
Well, I've been to Australia and yeah, involved with work in New Zealand. There's a cultural difference. Australia has a similar health insurance model to the UK. Just to show you the difference in mindset. It's very, very similar, except in Australia, they call it, I think they call it Medicare actually. And in the UK, they have many people. Everyone is in the national health system, but about 11% of the people have some private insurance that they use to maybe circumvent periodically. But the overall culture there is that we're all in this together, and we should all cooperate, and we all should have the same healthcare. That's a stiff upper lip approach. And you get New Zealand, which is quite interesting, same model, but about 50% or more of the people have private insurance too. They have the two. And more people use their private insurance because their culture indicates that if you can afford it, use it, saving the money for the folks who can't afford it in the public system. So it's the sacrifice of willing to make the sacrifice. And in New Zealand, it's heavy on the idea of fairness. The fairness concept seems to permeate a lot of their thinking. And I don't know why they behave the way they behave. I can't answer that. But their fundamental concepts are a little different than ours in the US, which is we do what we want. This is independence and freedom, etc. So I think there is some cultural differences that affect the behavior patterns.
Yeah, and there is a third model, This is the one of Singapore in a way, where you're whatever you're not going to spend on healthcare, the government will, if you healthy lifestyle and so on. I know we slip a bit from the topic of today, but if you live healthy and you don't cost too much to the public health system, guess what? What you don't spend is going to end up into your pension fund.
So it's all cultural. And the other thing that they've had in Singapore particularly is a good example, is that they have this this democracy concept and the freedom, and they vote, and it's small. It's a small country, small state actually, if we compare it to the U.S. But their idea is such that they've had a consistent leadership model in such a way that they are able to plan long term.
Yeah.
So when they said, for instance, that we are going to run out of water, because the water they were getting was coming from Malaysia and it would run out, they decided we want to become independent of water. So it took 10, 12 years, consistent concept, and they went to desalination and they're independent of water. But it took that long to get there, which in our country would outlive any administration. So we would need to have a common concept that carries it further for us to accomplish some of the big societal challenges that we have in our country without the consistent shared vision, I call it, of what the country really wants to do. Our visions get zing-zanged all over the place, and that's because we're independent. We don't really focus on really, as I say to my colleagues, when our politicians say they're doing this for the good of the American people, I always cringe. I always say, run for the hills. When our politicians say they're doing this for the good of the American people, that's exactly not what they're doing. Now, I promised I wouldn't be political, but that's my opinion.
So kind of a follow-up question to this discussion, what can we do, or how can we educate and influence policymakers to kind of do the right thing, and what is the right thing for the US right now as it stands in the pandemic?
Well, yeah, it's hard to educate politicians on the right thing, just like it is hard to run a course at Arizona State University and ask to do the right thing for the students. Each one has a different idea. It's right thing for what? If I'm a politician and I'm trying to represent a locality of House of Representatives, 700,000 people, I have to satisfy the 700,000 people. Their desires may be quite different. And besides, my right thing is to get reelected. So the right thing depends on your viewpoint. If they were going to try to do the right thing for the United States and individuals, I think there has to be some sort of a mindset where we have this shared vision we're trying to accomplish. In World War II, it was to beat the Germans. We went to war. Okay, that's the shared vision. Everybody is now aligned. We expect people to work in that regard. We had a draft. All the folks were involved. We had people on the front lines. There was a shared vision throughout the country. It didn't exist until we declared war. And once we declared war, because there was a lot of difference of opinions of getting involved until then. Well, in the United States, we have not declared a war since World War II. We've been in nothing but wars since then, but we haven't declared one. We've just turned over the responsibility of running the country to whoever is in the president, for instance. And the Congress has given them more and more and more freedom to do what they want, because I think Congress has abrogated its constitutional responsibilities. And one of them is right in the Constitution. It's their job to declare war, and we haven't had one that we've declared for a long time. We haven't had a mission or vision for healthcare in the United States. What is the vision for healthcare? Is it to make lots of people rich? Is it take care of only certain people who can pay full dollars? What is the vision in the United States? We pay a lot of money for bad care, discoordinated care, not integrated. We pay that money versus How do we change that? Do we start deciding, here's what we want and we value, we want to get better outcomes, lower costs? Well, if that's the case, we got to start paying for it. We got to change the way we are doing it. So I think, Natalie, and you know this, you and I have been around this a lot. It's the lack of a clear vision that has a long-term horizon in which we have a consistent drive to get there. And that gets diluted almost everywhere you go because of politics and the lobbying functions, the fact that the Bayh-Dole Act allows patents to last for a long time, 7 to 20 years, for discoveries that are paid for by our own citizens. Very tough. So I don't know how you do it without a shared vision.
And on that note, I think one of the questions came up was, what were the key strategies for success to bring these competing health systems to work collaborative? And I think the notion of vision that you just mentioned was probably one, and probably the most important one, but I wonder if you can comment on some of the others and how would that translate, if it would translate into non-pandemic times? Do you think it would continue? What would you need to put in place to make sure that it does?
Okay, that's a really good question. In this case, coming together around the pandemic was one that we started by really talking to the folks. What did you notice individually, each organization? What did you notice? What were some of the problems that you ran into? And can we improve them? And each one said, yes, we had these significant problems. They listed them, and yes, we can improve it, et cetera. And I said, well, should we be thinking about doing something here locally and setting a mission and vision statement that we would drive for and develop a shared vision? It was relatively, in my viewpoint, it was much easier than I thought would have been to make it work. And it's because the CEOs instantly were engaged. They said, this is a real problem and we have to have resilience and we have to be able to do a better job. So it was in their self-interest to make it work. What I observed during the discussions is that it was pretty clear this was a practice issue, caring for people, and therefore the CEOs were actually deferring appropriately to their chief medical officers. And the chief medical officers they're providing care. The nurses and the doctors, they were providing care. And for them to want to work together was almost a no-brainer, because this was for the good of the people they were caring for. So I think that led to the success. We have a long way to go. And as I tell everybody when we meet, we'll see if we're still working together in another month, 2 or 3. That'll be the measure of success. And that's why we generalized the title to emergency, because we could have a major fire. We had fires close to Phoenix, North Phoenix, recently, last summer. We have the largest nuclear power plant in the United States is about 50 miles to the west of Phoenix, for instance. There are things that could happen that we're not totally prepared for. So the idea is to start with something a little bigger than just the pandemic, use the pandemic as the prototype, but think of it bigger. And what's in the back of my mind is that if we can develop trust and if the people agree to continue to work together, maybe we morph this into a concept of, can we come together to think about providing better healthcare, higher quality healthcare, better outcomes, getting lower costs, and maybe even move it to health. Maybe get to the point, can we look at a bigger picture that matches ASU's charter? ASU's, as you know, the last sentence in the charter is to ASU to be involved in measurably improving the health of the communities in which it serves. So that's something that, as you look at the bigger strength of it, we might be able to move in that direction. But if we can't hold it together around the pandemic, we're not going to do the others. So I think that's my ultimate goal with it. But right now it was around a common vision for a problem that was affecting all of them, and it had to do with clinical care. And I think we can make the same case for health, and we could make the same case for the impact on businesses with regard to having better health. But that's a future discussion for another day.
Now, no, I wonder if you can also comment, again, from a global standpoint, since the World Economic Forum obviously works with a whole breadth of partners. What do you think, again, are some of the keys to success to bringing them all together, keeping them engaged, and so on?
Well, I think this is like Dennis said. I think it's not a one-off. It's not a one-off. It's going to happen again. So I think when we think about preparedness, surveillance, supply chain matters, trade matters, we have learned so much in the past period that I think mobilizing financing and commitments to actually maintain those instruments that have been helpful. You mentioned before, Dennis, I mean, payment reforms for telemedicine. Well, it has been a patch. It has not been a reform. We don't know if it's going to be maintained. So I think those instruments that have been good need to be maintained and cherished. And the gaps that we know are in existence, such as the ones I mentioned, when it comes to surveillance, need to be addressed. And that's an absolute global emergency. And frankly speaking, it starts also at the grassroots, and doing it at the local level, like you're doing it with ASU or Banner or Kaiser Permanente, systems that I admire, is the right thing to do.
Well, we're almost out of time. I would like to thank both of our presenters and panelists today for their presentations and the Q&A. Thanks for everyone for attending, for your questions. I apologize if we weren't able to get through all of them. There were some really good ones, but we hope we were able to answer a few that were of interest to many. And now I'm going to turn it over to Nate to finish it up.
Thank you, Natalie. That's all the time we have for today. We hope you enjoyed the conversation and took away some new ideas or knowledge. We encourage you to follow the College of Health Solutions on social media, as you can see on the bottom right-hand side of your screen, so that you can learn about other health-related events and opportunities like this one. Please save the date and register for our next Health Talks webinar, also free and also approved for CEUs. The title is Dueling Epidemics, the Opioid Crisis in the Era of COVID-19, which will be on Thursday, January 21st from noon to 1 p.m. You can find info about our upcoming Health Talks. We offer one each month at asuhealthtalks.com. That is also where you will find the recording of today's talk if you want to go back and review it again or share with your colleagues. Please note, in order for you to get continuing education credit for our talks, you need to listen to the webinar live, as you've done so today, and complete the post-event evaluation survey that you will receive by email. Thank you again for joining us, and have a great rest of your day.